Thank you. Thank you, respected chairpersons. And thank you very much, Dr. Hemant, to giving me an opportunity to be part of this workshop on pulmonary function test. And my topic for today is physiology of pulmonary function test. Thank you. So, to understanding the pulmonary function test, the physiological part is very important. So I'm covering the important aspects, physiological aspects of the pulmonary function test. Respiration comprises of two processes, which is internal respiration and external respiration. Internal respiration, also known as tissue respiration, it is actually the production entry of oxygen into the tissue and then production of CO2, which is expelled out from the lungs. Whereas the external respiration, it has three major events, which is pulmonary ventilation, pulmonary diffusion, and transport of gases. Pulmonary ventilation is a simple entry of oxygen inside the lung and the exit of CO2 outside the lung. Whereas pulmonary diffusion, it is the diffusion of oxygen through the blood into the tissues and then CO2 out of the lung through the blood, passes through the blood. And transport of gases, it is in the various form, it is dissolved in the plasma and major part with the hemoglobin. So before going to the pulmonary function test, you must know about the functional anatomical part of the respiratory system. The upper respiratory tract, which encloses nostrils, nasopharynx, oropharynx, and the larynx. Where the lower respiratory tract, it includes trachea, bronchi, lungs, and alveoli. Another very important part is tracheobronchial tree, which is the basically the bifurcation of the different parts of the respiratory tract, which is started from the trachea, then right and left bronchioles, principal bronchioles, then lobar bronchus, then segmental bronchus, and then terminal bronchus, and then finally the respiratory bronchiole, alveolar duct, and alveolar sac. The functional anatomy is important because it is important because it is some part is utilized for the movement of the air inside the lung and some part is utilized for the proper exchange of the gases inside the lung. So this tracheobronchial tree, it is divided into two zones from the functional point of view. One is conducting zone, another is respiratory zone. The conducting zone is it contains the parts from the trachea till the terminal bronchioles, and they are also giving some numbers, and this is known as generations. So from 0 generation to 16 generation, this is a part of conducting zone, and this conducting zone is basically utilized for the movement of air. There is no exchange of gases in this part. So this is basically comprises the dead space. So from the right from the nostril, which is air present in the nostril, till the terminal bronchiole, it is a dead space, and the capacity is around 150 ml. Whereas the respiratory zone, it starts from 17th generation till the 23rd generation or till the alveolar sac. So this part is basically utilized, or there is an exchange of gases occurring in this part, and that is why it is very important part, because the exchange of gases takes place, and this is known as respiratory zone. Another important aspect is there is a total cross sectional area of the conducting zone is small, which is around 2.5 centimeters square, whereas the total cross sectional area of the respiratory zone is about 12,000 centimeters square. So because of the small alveolar sacs and alveoli, the total surface area is increased, and this helps in the exchange of the gases at the respiratory zone. And it is looks like an inverted funnel shape. This is the conducting zone, which is the average diameter is less, whereas due to the bifurcation of different alveolar sacs, the respiratory zone has larger area, surface area. So there is a more exchange of gases takes place. Now, next is mechanics of respiration. Breathing refers to the inspiration and expiration of air into and out of the lung respectively, whereas respiration means the breathing along with utilization of oxygen and release of CO2 by the tissues. So this respiration consists of two parts. One is inspiration, which is the movement of air inside the lung, which is a smaller and is around 1 seconds of duration, whereas the expiration is a longer duration, was 3 seconds, and it includes the exhalation of the CO2 out of the lung. To understanding the mechanics of inspiration, and it is by increasing the intrathoracic volume. If you remember the Boyle's law, it states that at constant temperature, if you increase the volume, your volume of gases is inversely proportional to the pressure of the gas. So this law is holds true in case of process of inspiration. So mechanism of inspiration is utilized by two mechanism, basically by increasing the intrathoracic volume, and this intrathoracic volume is done by the two mechanism. One is pump handle movement, which is occurs in the first 6 ribs. The usually at resting position, the ribs they are towards the backward and forward position, but during the inspiration they move outward and forward, outward, and it causes more attain more parallel position with the connection with the spine. So it moves the your sternum forward and it increases the anteroposterior diameter. The anteroposterior diameter increases and increase the volume of intrathoracic cage. So it helps in the movement of the air inside the lung. Another is bucket handle movement. This occurs in the 7th to 10th ribs. In the 7th to 10th ribs, it causes the during inspiration the ribs moves outward and upward, and this increases the transverse diameter. So both these mechanisms increase the intrathoracic volume, and once the intrathoracic volume increases, is decreases the intrathoracic pressure because of utilization of the Boyle's law, and due to the negative intrathoracic pressure, it causes the movement of air inside the lung. Another is by decreasing the intrathoracic pressure. Usually, if a balloon is taken and if you pull the air inside the balloon, which is positive pressure, you are giving the blow outside and air moves inside. And this is the positive pressure filling. Whereas in our lungs, this is done by the negative pressure filling. And it is like if you a closed chamber is there, a balloon is attached, one chamber, and there is a rubber diaphragm. If you pull the rubber diaphragm downwards, it decreases the inside pressure and make the pressure inside the box is negative. And this air is in the which is present in the atmosphere is moves automatically inside the balloon. So this is what happens in the our thoracic cage, and this automatically fill the air during the inspiration. So do you remember any animal which is done inspiration with the help of positive pressure filling? Any animal? MBBS students? पढ़ाया गया है. Frog, very good. Amphibians, what they done for inspiration, they engulf the air inside the mouth, and there is a balloon like sac inside the mouth. They fill the air and then push the air inside the lung. So this is by the positive pressure filling, whereas in ourselves, in human beings, this is done by the negative pressure filling. So this expiration part is automatic. This is due to the recoil of the lungs, and the muscle of expiration is required only during the forceful expiration. The internal intercostal muscle and anterior abdominal muscle, they pull the ribs downwards and increase the intra-abdominal pressure and push the diaphragm upwards, and this causes the expelled out of the gases from the lung. Now the pulmonary function test. These tests are conducted for assessment of functional status of the respiratory system are called as pulmonary function test. They include the lung volumes and lung capacities, lung volumes like tidal volume, inspiratory reserve volume, expiratory reserve volume and residual volume. Whereas lung capacities, which includes two or more lung volume, and they are inspiratory capacity, expiratory capacity, vital capacity, functional residual capacity and total lung capacity. They are also classified according to the static lung volume and capacities and the dynamic lung volume and capacities. Static कब बोलेंगे when we are not taking the time part of the it only the net change in the volume which is measured. There is no involvement of time. Whereas dynamic lung volume and capacities, the rate of change of lung volume per unit time is measured. So tidal volume by definition, the amount of air breath in and out in a single breath at the resting stage. It is around 500 ml. Inspiratory reserve volume, the maximum amount of air that can be inspired at the end of normal tidal inspiration with the maximum inspiratory effort. And this is around 250 to 200 500 to 2500 ml. Expiratory reserve volume, the maximum amount of air that can be expired out of the lung at the end of normal tidal expiration with the maximum expiratory effort, and is around 1200 ml. Residual volume, it is the amount of air present in the lung at the end of maximal expiration, and this air cannot be expelled out from the lung even with the maximum expiratory effort, which is around 1200 ml. Now the capacity, like inspiratory capacity, it is a maximum air inspired after tidal expiration with maximum inspiratory effort, and this is include the inspiratory reserve volume plus tidal volume, and it ranges from 2500 ml to 3700 ml. Then the expiratory capacity, which is a maximum air expired after tidal inspiration, and it includes expiratory reserve volume plus tidal volume. Vital capacity, maximum air expelled from the lungs by forceful efforts after maximal inspiration, and it is 4.8 to 3.2 liters. It varies uh, with the gender, more in male, less in females. Body surface area, it affects by the position of the body sitting. There is a difference in the standing, in the supine, this is changed. So total lung capacity, it is air in the lung after maximal inspiration, which includes the vital capacity plus residual volume, and it is around 6 liters. Functional residual capacity, it is the amount of air present in the lung after quiet tidal expiration. It includes residual volume plus expiratory reserve volume, which is around 2.2 liters. This functional residual capacity is important because of this FRC, the exchange of gases is possible during at the expiration also. If there is no FRC or residual volume, it is not possible as to do the exchange of gases during the expiration. Then the closing capacity volume at which the smaller airways in the dependent area of lung start closing. And this is the graph we get during the student spirometer, and this is known as spirogram. It includes the tidal volume, it includes the inspiratory reserve volume, tidal volume plus then expiratory reserve volume, residual volume, and then this is the inspiratory capacity, vital capacity and the total lung capacity. Then the dynamic lung volume and capacities, they are the force expiratory volume. It is also called as timed vital capacity. It is the volume of air expired forcefully in a specified time interval. and it is divided into FEV1, which is the maximum amount of air which a subject breath out in first seconds of forceful expiration. The normal value is 80, more than 80% of FVC, and FEV2, which is 95% of FVC, and FEV3 is which is 98 to 100% of FVC. Then there is a expiratory flow rate at which air expelled from the lungs during expiration, and they have divided in four phases. Maximum expiratory flow rate 25%, MEFR 50%, MEFR 75%, MEFR 100%. Basically it is denoting the just smaller airways होते हैं, how they are functioning. We check the functioning of the smaller airways with the help of this expiratory flow rates. Then the peak expiratory flow rate, PEFR, is the maximum speed of expiration achieved during a forced maximum expiration from the lung, from full lung inflation. It is 5 to 15 liter per second in male and 2.5 to 10 liters per second in females, or you can say 450 to 700 liter per minute in males and 300 to 500 liters per minute in females. PFR हम बेड साइड टेस्ट है, इसको हम पीक राइट पीक स्पायरोमीटर से कर सकते हैं. इट इज यूजुअली यूटिलाइज फॉर differentiation between the you can say obstructive diseases, whether they are the uh, because of giving the some bronchodilator, they are reversible or irreversible diseases. So we can check bedside with the help of peak expiratory flow rate. Then the maximal mid expiratory flow rate is a measure of airflow during the middle portion of the forced expiration. It is also known as forced mid expiratory flow. Then the other method, this is what I am telling is the basic of PFT, and for further evaluation of the PFT, we have today's workshop is based on this only, like DLCO, diffusing lung capacity of lung for carbon monoxide, 6-minute walk test. The newer test includes in the PFT fractional inhalation of nitric oxide, body plethysmography, cardiopulmonary exercise testing, bronchoprovocation testing, and force oscillatory techniques. So these are the different PFT which give the broader information or advanced, you can say, PFT included. So that's it from my side. From the physiological part, we just tell about the normal functioning of the lung, how they are functioning, and thank you.